Do you want me
I'll.
to wait 5 more minutes, maybe?
Oh yeah, yeah, certainly, yes.
Yes. Yeah, we'll do that. We're good. Thank you.
Are you on the week of attending this week?
Say that again, please, Bunny.
Are you attending this week
Um,
as a staff
not
attending?
not officially,
Okay.
but you will know what that means.
Yes, I know.
Mhm.
It's a small world.
Yes, indeed.
We'll just have 1 more minute before we can start.
Thank you.
Okay, Leo, I think we'll start now. We've got nearly 50 people now. Um, Good evening, everyone in India, and very early morning for Leo. Thanks for joining in on the topic of pediatric thrombosis and its management. We've got a very eloquent speaker, Professor Leonardo Brandao, very well known to people who've actually graduated from SickKids. A brief introduction about Leo, as we call him with love. He graduated medicine from the University of Sao Paulo, Brazil, and he did his residency in general pediatrics from a renowned university, Emory University at Atlanta. He also did his fellowship in pediatric hemonc at St. Jude's at Memphis. He did his pediatric coagulation fellowship at Weill Cornell University in New York. And then he moved to University of Toronto in 2004, and he remains at University of Toronto as a staff hematologist. He started the pediatric thrombosis department, and he's built it with great passion. He's also a professor at the Faculty of Medicine and at the Dalla Lana Faculty of Public Health, both at the University of Toronto. He has varied interests, and his main academic interests includes describing the short, medium, and long-term effects of thrombotic events in children, as well as promoting training in pediatric thrombosis for so many candidates from all over the country. He's had at least 54 trainees from across 25 countries. He's the apt person. He provides guidance, and he is one of the guideline panelists in thromboprophylaxis and treatment of thrombotic events in pediatric patients from national, which is Thrombosis Canada, CPTHN, and international societies such as ASH, NISTH. He's also a proud husband of one of my very, very dearest friend, Dr. Laura Avila, who is also a thrombotic consultant, and a proud father of Mateo. Thank you, Leo, for having you here and graciously accepting our invitation. Over to you, Leo.
Thank you very much, Dr. Sivaprakasan, and if I dare say Pony, and to review so many colleagues and friends. I apologize for not being able to give this presentation in person, and I'm very honored, and I thank the organizers, especially Pony, for allowing me to share a few thoughts with you on a topic that is dear to our heart. Thank you for your tremendously generous, overstated introduction, and in the next 35, 45 minutes or so, maybe if I can put this on slide mode, hopefully, and I will start advancing the slides, if that's okay. We will briefly review topics related to diagnosis and treatment of thrombotic events in children, both venous and arterial territories, brain and outside of the brain. So I do have the disclosures that Dr. Sivaprakasan shared, being a panelist on national and international endeavors, and we have received research funding from different sources that all go to the studies, of course. I will be, because approximately at least 80 to 85% of anticoagulants have not been accepted by regulatory agencies internationally. Most of what I will be discussing will be considered off-label. So perhaps we will have 10 to 12 minutes for each of the three bullets that summarize our three main objectives this evening. Briefly review the epidemiology of thrombotic events in children, followed by very brief notions regarding diagnosis, highlighting the most common types of events according to age groups, and then we will finish with a brief overview from the last 10, 15 years on guidance or evidence-based guideline recommendations for these population. Starting with the epidemiology. So we jump right in a series of histograms or bar graphs. The first one is representing on the horizontal axis from 0 on the left to 18 years of age on the right. We see the distribution of, I'm always going to say venous first and arterial second. In the brain, the venous occlusions surmise mostly cerebrovenous sinuses, and CSVT standing for cerebrosinus venous thrombosis. We can see a bimodal distribution. This is one of the initial national reports that was headed prior to my time here by Dr. Gabriel de Weber, who had mirrored the initiative that I will share with you in a few slides down the road. And this is data coming from all the pediatric referral centers in Canada. So we can see a preponderance of CSVT pediatric events during neonatal period, followed by a second peak during adolescence. The overall mortality, which highlights to us that children that develop CSVT are usually not healthy, was 8%, with cerebral venous directly related mortality of 4%. The other side of the coin will relate to pediatric arterial ischemic strokes. And this is again borrowing from Dr. De Weber's National Arterial Registry from Canada, much more common. You can see a tenfold difference north of 1,000 patients. And here we again see a preponderance not only in neonates, but in infants and even toddlers. Whereas for CSVT, almost half of the events occur during the neonatal period. For arterial strokes, almost between a quarter to a half will occur up to the age of 2. And hopefully you can also identify the overall mortality of being 12%, but the arterial stroke direct related mortality of 5%. Two very brief comments, one on the venous, as I told you, and then a second on the arterial. In terms of incidence, you can also see a 2-log difference, actually 3-log difference of the incidence in neonates in contrast to non-neonates, a um, higher prevalence or rather incidence in the male sex, and in the neonates, most common risk factors being hypoxia or fetal distress or babies born from instrumental delivery. And from the maternal point of view, females that had diagnosed chorioamnionitis or diabetes, pregnancy-related diabetes or preeclampsia. The location, understanding the most or the highest surface relates to the superficial cerebral sinus venous territory in contrast to the deep, which is represented. Hopefully you can see my arrow. This would be the deep venous system and this would be the superficial venous system. So the superficial venous system is the one most commonly affected. Flipping the page, I will also now give a very brief summary on the follow-up epidemiology in children with arterial now. I had already alluded to the fact that neonates have more commonly this complication in contrast to non-neonates, perhaps not with the same difference in contrast to venous. Again, a preponderance of male sex with a tremendous impact on the child's future life and family and society, as it will affect overall lifespan, productivity, and so on. The medial artery, as you just have the circle of Willis represented on the right part of your slide, will be affected in more than half of the time, followed by internal carotid territory, anterior, posterior, and then anterior choroidal arteries. These are the categories of pediatric types arterioischemic strokes. The most perhaps common, the cardioembolic type, followed by arteriopathy, and then followed by cases associated with acute versus chronic disorders, and then inherited thrombophilia. The difference between the more bright red color in contrast to the darker to the very right of each of the subgroups of strokes. And you see marked with asterisks where one subtype is more common in neonates in contrast to non-neonates. It's always important for physicians that face scenarios that are potential arterioischemic strokes to remember that perhaps in an emergency room setting, three out of 4 children that will come with a suspicion of an arterioischemic stroke have non-stroke related etiologies. We call them stroke mimics. And hopefully you can see a summary of the most common diagnostic differentials highlighted in this slide, from seizures secondary to hypoglycemia to, of course, brain tumors, post-seizure ictal findings such as Todd's paralysis, complex migraine, posterior reversible encephalopathy, and conversion disorders, for example. Now that we've very briefly summarized venous and arterial events in the brain, take the liberty of doing the same from the neck down, if you will. Again, starting with venous, in contrast, the information to arterial. What you see here again, an age distribution according to number of children reported in the original Canadian thrombophilia study in 1994, when a nurse was flown to each of the Canadian pediatric referral centers to collect the data by hand. We see the original report showing an incidence of 5 over 10,000 hospitalized children. And the second number you see of 100 was reported from referral centers in the United States, showing a tremendous growth secondary to increased awareness, improvement in imaging techniques, and uh, more and more aggressive pediatric medicine that patients pay the price to continue to survive. Similar to what I had said before in terms of the type of children that endured thrombotic events, mortality overall of 16% in these children with an venous specific mortality of the Canadian registry in 1994 reported at 2%, and nowadays as high as a matter of fact, not 1 in 4, 1 in 3. That depends on the underlying condition and location of where the venous thrombus is. In contrast to the bimodal curve, similar to the CSVT that I had shown before, with accumulation of cases in the patients aged less than 1 year or during adolescence, the distribution of events in the arterial trees differs, as you see now. This is a single center quaternary Australian hospital report from Melbourne from a previous trainee from the thrombosis program at SickKids. And here we see the overall mortality of 11% and arterial thrombosis related mortality of less than 10%, with a vast majority of events occurring within the initial year or initial 6 months of life. I am now summarizing to you 50 years of the history of description of venous thromboembolism in children. We start with reports in adult facilities that had pediatric beds, evolving to national registries throughout the world. I bring to your attention for comparison what I had already alluded. The first in the Canadian registry, please take a look at the difference per 10,000 hospitalizations or live births. 0.07, so let's facilitate and make 0.1 per 10,000 in contrast to 5 per 10,000 admissions, making the point that in healthy children, venous thromboembolism is certainly rare. And then fast forward in 20 years or so, 30 years or so, excuse me, we see the prevalence in a hospital setting, tertiary or quaternary hospital setting, in 5 to 10,000 to 100 to 10,000. Not only has this happened in pediatric setting, in neonatal intensive care unit setting, it has also happened in the same manner. This is data from an administrative group of NICUs from the United States, with a total of north of 1 million infants admitted to NICU facilities, with a prevalence, or rather incidence, of 0.2% of neonates, with including here both venous and arterial events. Risk factors related to patient's age: the younger the gestational age of the patient, the higher the odds ratio towards developing thrombotic events. The burden of developing an arterial or venous event was reflected on mortality, thrombosis positive 11. It says mortality, it's 11%, not days, versus 2%. And then hospital stay, almost an extra 6 weeks, an association, not causality, because this type of data does not allow us to conclude causality. And finalizing, additional risk factors for development of the thrombosis: Black and Hispanic ancestry being protective in contrast to Caucasian, and then conditions, underlying conditions, congenital heart defect, presence of central lines, mechanical ventilation, use of erythropoietin, post-surgical events, or in the event of sepsis. Perhaps I can conclude the final part of this talk. Uh, I hope you agree somewhat with me that thrombotic events have a variety of phenotypes in children. I will expand on that. Neonatal populations, particularly in critically ill, are more commonly affected by both types of thrombotic events, and there are important nuances in patients, mostly neonates, including mechanisms, types of presentations that should be considered, in the decision making of acute and long-term treatment. This is a brief look at the famous CN Tower that is perhaps a hallmark of Toronto with beautiful blue skies. Let's move, if that's okay, towards a second part of our talk, which is very briefly stress the lack of specificity of the most common type of thrombotic events when they present. So I will show you 4 slides for the most common venous and then arterial events. And I'll start with the neonates. I had already mentioned half of the cerebral sinus venous events occur in neonates throughout childhood. And we can see to the right of the slide most common presentation, identifying perhaps they lack specificity and sensitivity for a clinician because several other causes can lead to seizures, lethargy, and poor feeding and apnea. Outside of the brain, perhaps the more dramatic neonatal venous thromboembolism that may happen in the form of ultra rare severe congenital protein C deficiency leading to purpura fulminans, but there the presentation is perhaps a bit more specific. You have cutaneous purpuric lesions, biocular in general, bleeding, and retinal detachment, and then eventually venous occlusion leading to limb swelling. For renal vein thrombosis, the most common non-catheter neonatal finding, hematuria, flank mass, and thrombocytopenia that only 20% of patients with renal vein thrombosis present. Perhaps a more common one that is umbilical venous catheter related is portal vein thrombosis. And then long-term, patients may be identified after defect because of increased abdominal venous superficial collaterals, hepatosplenomegaly, and GI bleeding. And then certainly in neonates, most commonly they develop central venous catheter-related limb DVT, accompanied by perhaps not so specific findings, limb swelling, a bit of warmth, and eventually paradoxical strokes. Now that we review the most typical neonatal venous thrombotic events, here in this next slide, you see the most common venous events in non-neonates. So throughout the rest of the childhood, the other half of CSVTs will occur, and we already made the comments on their most common clinical findings. In females, or nowadays individuals that are taking sexual hormones in transgender care, we have hormonal-related risk factors leading to limb DVT. Of course, central line-related DVT is a very common throughout childhood, and then in adolescence, inflammatory bowel disease, rheumatologic conditions such as lupus, with secondary nephrotic syndrome, cancer related in the non-adolescents, acute lymphoblastic leukemia and adolescent sarcomas and lymphomas. And then on the late adolescent time, idiopathic or non-catheter related DVT and PE. Except for the renal vein that I had already shared the classic triad that only 1 in 5 patients will have. For limb DVT, we have already also reviewed the findings that perhaps lack complete specificity. You can have soft tissue issues related to infection, abnormal growth, or anatomical findings. And therefore, clinicians may rely or need to rely on biomarkers and imaging. In terms of arterial, for neonatal presentation, we had already reviewed arterial ischemic strokes, but the three main non-CNS are caused by arterial catheters or umbilical arterial catheters, aortic catheters, or uh, post-cardiac catheterization, mostly affecting limbs. And for the aortic ones, there may have distal findings. In the non-neonate, with arterial events. So on that post that very brisk peak that occurs within the initial 6 months, there may be conditions. Of course, in the school age, Kawasaki disease affecting the coronary artery disease, because in non-IVIG treated patients, 25% of the coronaries may develop aneurysms, and in IVIG treated 5% or less, and other conditions during adolescent years, such as Takayasu's disease affecting the abdominal aorta, for example. If perhaps the clinician needs to rely also on biomarkers, and because such events are most common in hospitalized patients, our center embarked on an investigation or comparing limb suspicion for DVT in 300 children aged 0 to 18 years of age. On the left part of your slide, because these are hospitalized patients, I have a comparison of the D-dimer value, which is a biomarker of acute DVT, and hopefully with the red line, that is the cutoff, for assay positivity depicted by the company. So you can see that both DVT positive and negative there, and the box plot shows that the patients were all almost entirely, almost 75% of them uh, above the company's cutoff. But most importantly, the lack of uh, capacity of the test, this laboratory test, to differentiate DVT positive and negative. And that is easily understandable because these hospitalized patients have inflammation from their underlying condition, infection that will make D dimers falsely positively elevated with the area under the curve that is as good as the flip of a coin. So perhaps I will conclude the second part that venous and arterial thrombotic events, um, the most common ones, not necessarily have specific findings, and therefore the clinicians should keep a high level of suspicion that may need to be accompanied by auxiliary radiological and laboratory investigation so that the diagnosis can be formalized and finalized. This is a beautiful picture in the province of Ontario, taken in late spring with our son when we were going to do apple picking. And the final third of the talk, I think we still have around 10 to 15 minutes in place, is first to review the profile of the most common anticoagulants used. This table alone shows the big three that I'm going to call. The column 2 and 3 summarizes the uh, characteristics of heparinoids, unfractionated heparin on the second column, mechanism of action, most common modes of administration and the half-life, how to monitor it, the fact that it has a perfect antidote, and to the left, the major bleeding complication according to international classification, refracted by randomized trial on the first number, 12.5%, and then in intensive care unit as high as 1 in 4 patients exposed to full dose. In contrast to low molecular heparin, the same characteristics, and you see the major bleeding complication to the left from systematic reviews, and to the right, 5.6% from randomized trial, and finally, the oral vitamin K antagonists that actually inhibit 14 different vitamin K dependent proteins, of which I will bring to your attention coagulation factors 2, 7, 9, and 10, and also protein C and S. The fact that it has another perfect antidote that, depending on the route of administration, oral or IV, will start the reversing between 6 to 12 hours or greater than 24 hours. And then the major bleeding complication, 12.5% from randomized trials or from cohort studies, 0.5% per patient year. 12% IV heparin, warfarin, 5% low molecular heparin. I repeat these because now I'm going to contrast them with a summary of a wave of randomized pediatric trials that have compared direct oral anticoagulants to standard of care anticoagulants. We can see almost 1,000 patients, so the upper right corner brings the total number of children exposed to one of the four compounds that you can see: rivaroxaban, dabigatran, apixaban, and edoxaban. Hopefully, I have highlighted the rate of recurrence between 0 and 4%, and the 4% comes from a trial where there was a higher than usual thrombophilia prevalence. And hopefully you can also see on the next slide, this is a summary of major bleeding complications from the same trials. The red blood cell bag reflects major bleeding, the 3 drops of blood, clinically relevant non-major bleeding, and the 1 drop minor bleeding. So for major bleeding, we have between 0 and 2%. Remember the previous numbers, 5 and 12%. Clinically relevant between 0 and 3%. And for minor numbers that are very comparable with standard of care anticoagulants. Finally, this hasn't been published yet, but uh, I, I, I presented this at the last ISTH meeting in Washington the last summer. One of the reasons is that the 2 key pivotal manuscripts have not been peer review published yet, the last 2 that reflect the safety and efficacy of apixaban and edoxaban respectively. But hopefully we can see the diamond bringing the aggregate of recurrence in contrast to standard of care treated patients. Approximately 800 patients treated with DOACs and approximately 500 treated with standard of care. That it was DOACs were non-inferior to standard of care, representing a tremendous improvement because the patients would not need to receive subcutaneous injections or the frequent laboratory monitoring. I will now continue to summarize in one slide. Here you see the covers of, on the left, the historical chest evidence-based guidelines initiated in 1995, which derived from, in the middle, you see the cover of the first Sick Kids pocketbook made by the late Dr. Andrew and Gabrielle to the fellows to help them doing call. And the chest guideline that you see on the left derived from this very pocketbook. And to the right, the very recent last ASH ISTH updated guidance on this matter. Here we see a gist of the major flavor and the nature of how the guidelines or guidance was conducted. The year of publication is shown on the third column. The level of evidence being expert opinion or evidence-based without the use of grade recommendations are also shown. And again, the major flavor, if I was to resume, was that initially anticoagulation relied on treatment with a heparinoid for 5 to 10 days before transition to an oral vitamin K antagonist could be made for at least 3 months of anticoagulation full dose duration. This is also reflected with a higher color or usage of enoxaparin on the sick kids call handbook. And then the first evidence-based, the British published showing similar recommendation, stressing on the use of low molecular heparinoids. Chest guidance was finished the very last iteration in 2012. And we evolved from 23 to 121 recommendations, 2 out of 3 or 3 out of 4 on grade 2C. So opinion-based, really. Uh, enoxaparin in a second low molecular formulation, and we currently have between 5 and 8 low molecular heparin formulations used worldwide in children. And then in 2018, the ASH guideline started to be published, the first one, and DOACs were purposely excluded from that guidance document. The up-to-date, which is what most trainees use globally, have incorporated DOACs, and the statement related to DOACs is that was acceptable for patients, for adolescent patients, and non-acceptable for infants, with perhaps use of parenteral agents in the initial 5 to 10 days that date back to 1994. And the very last one that favors the use of dose in contrast to all of the other anticoagulants, mostly rivaroxaban and dabigatran, which were the two anticoagulants or DOACs approved by regulatory agencies, that is EMA in Europe and FDA in North America or United States. I was asked to make brief comments on thrombophilia, a very controversial topic. And in 3 slides, I will hopefully share what the field has produced. The very first ISTH, it's not 2022, my apologies, it's 2002. The very first 2002 recommendation on this topic was made by its respective pediatric SSC, recommending universal testing for thrombophilia in neonates, children, and adolescents to be conducted in a tier manner, meaning the most common laboratory tests for thrombophilia first, and then a second tier investigation and a third, but everybody, because it was a time where thrombotic events were still starting to be recognized in children. A few years, the ACCP CHESS guideline was the only CHESS guideline that voiced their opinion on this topic, and they were a lot more economic, suggesting screening for congenital thrombophilia, not recommending universal testing, that screening was of improving benefit and was a lot more reticent without clear recommendations. The second slide brings 2 or 3 publications that started to change the opinion from going from universal, excuse me, to a more scenario-related indication. And this comes from studies done in the Netherlands by Helene van Omen, showing that in young children with CVL-related thrombosis, there was no role to investigate thrombophilia to predict recurrence. And then studies done in Germany and in sick kids in Canada that showing that perhaps there was certainly a role to conduct that in adolescent patients with non-central line related venous events. Now I'm going to fast forward to an unpublished statement that will be presented in Paris in this upcoming summer. I will have the honor to presenting these upcoming ISTH pediatric SSC recommendations. To the left, the positive ones. That first, that plasma-based tests must be compared to age and coagulometer appropriate laboratory reference ranges. Hopefully in the future, we'll be able to add 3 categories to the comparator values: age, coagulometer, and ancestry appropriate laboratory reference ranges. Number 2, that inherited investigation for inherited thrombophilia, namely protein C and S, is indicated in patients of any pediatric age with suspicion of congenital purpura fulminans or a non-sepsis-driven DIC, disseminated intravascular coagulopathy. Children, particularly adolescents, similar to the 2004 perception with unprovoked VTE, or in whom the thrombotic event is disproportional to its thrombotic risk factor, should be considered. And finally, children with recurrent non-catheter related venous events should also be considered. The right side of the slide will now bring you the negative recommendations, disfavoring investigation in patients with venous or arterial catheter related events, which is the vast majority of the children we've just reviewed, or testing in children with neonatal arterioischemic stroke. And I will finalize with a summary of the recently published updated ASH ISTH guidelines. Here, the panel was able to confirm recommendation towards treatment to the left. So to the left, we see recommendations towards treatment for children of any age with cerebral sinus venous thrombosis, with or without hemorrhage, secondary to venous congestion. We also see recommendation favoring anticoagulation in children with symptomatic deep vein thrombosis or pulmonary embolism. We see favoring recommendation again in children with occlusive or non-occlusive post-liver transplant or not, or unprovoked portal vein thrombosis. And in neonates with occlusive portal vein thrombosis, we see positive recommendation for high-risk features, that is, depending on the size, bigger size on right atrial thrombosis, and low perceived bleeding risk. Positive recommendation for neonatal renal vein thrombosis and non-cannula related lower limb superficial vein thrombosis, or in the instances of cancer, or in the instances of varicose vein. The panel recommends against anticoagulation in clinically unsuspected DVT and pulmonary embolism, or in the portal vein in the presence of portal hypertension, or in neonates with non-occlusive portal vein thrombosis, or in right atrial thrombus without high-risk features, or in superficial vein thrombosis secondary to the presence of annulation. Sorry to rush, but this is a very brief summary of the entire ASH ISTH recent 2025 recommendations. In terms of type of anticoagulants, I had already alluded, they favor DOACs, that is dabigatran and rivaroxaban, over standard of care, except in the presence of so intestinal failure, where there is obviously decreased absorption, recent surgery, liver disease, kidney disease with a GFR less than 30, antiphospholipid syndrome, preterm neonates, or active cancer. And finally, I will bring to your attention the very important Kids Dodge trial that took 14 years to be completed, showing no inferiority comparing 6 weeks to 3-month duration. But it's important to point out cancer patients, patients with inherited thrombophilia, recurrent event, or antiphospholipid were excluded from this trial. And therefore, duration from the ASH guideline recommends 6 weeks of duration only if at 6-week mark the ultrasound shows non-occlusive venous thrombus, excluding the high-risk groups removed from the Kids Dot trial that should therefore be treated for at least 3 months, and unprovoked between the duration between 6 and 12 months suggested. Finally, thrombolysis is recommended by the panelists of this guideline only in the instance of life-threatening renal vein thrombosis in neonates, or only in pulmonary embolism accompanied by hemodynamic compromise. For the other venous thrombotic event areas, thrombolysis up front is recommended. And I'm sorry, I'm about to finish with final remarks that thrombosis in children is accompanied by morbidity. It's particularly happening in hospitalized patients The role of anticoagulants, hopefully, shown you, it has been well established, and the current recommendations vary according to subspecialty and jurisdiction of what you have access to in terms of anticoagulants. But importantly, the other side of the equation, whenever we talk about anticoagulation, is bleeding risk, which are not so well characterized in the pediatric population. And that's certainly a gap that the next few years will bring more attention to. If you liked what you heard, uh, because of the extension of the training program that Dr. Sivaprakasan shared with you, the fellows decided to write a handbook, and this is the handbook in its third edition. It has uh, a much broader view of what I've attempted to summarize to you, and I'm sharing the Picasso, very famous painter uh, here from Canada, Mr. Morisot. And I will thank you again for the opportunity to share. Just a few weeks back, we still had a lot of snow here in Toronto, and hopefully we can discuss several topics. Thank you very much for this opportunity.
Thank you so much, Leo. Um, I think I'm going to let Arun take over for the question session.
Thank you.
Thank you so much. It was such a brilliant talk,
Thank you.
as always.
Thank you,
Thank you,
Pani.
Prof. Yeah. So thank you, Prof, for such an excellent talk.
My
Although
pleasure.
with this talk, I think most of doubt is clear. There are only a couple of questions in the chat box. If you allow, we'll ask few of the questions.
Of course.
Yeah. So from Dr. Anjani is asking one case scenario. One 12-year-old boy with extensive iliofemoral venous thrombosis on background of likely IVC abnormality, and along with that, there was significant family history of thrombophilia. In the absence of any limb-threatening feature, conservative management with therapeutic anticoagulant with low molecular weight heparin, or role of DOAC, and if yes, which one and when we can start. And along that, there is family history of heterozygous factor V Leiden mutation in mother, along with hypofibrinogenemia. So what is your take on this scenario?
Thank you very much for the question. Let me repeat to see if I understood. It was an adolescent patient, like looks like a boy with
Yeah.
extensive iliofemoral venous thrombosis, and particularly when iliofemoral thrombosis occurs on the left side, or not uncommonly in adolescents bilaterally, we would think on the left side of an anatomic abnormality called May-Thurner syndrome, or if it's bilateral, of IVC anomaly. Now, the problem may be precipitated by a second risk factor. The mother has 5 Leiden. I don't know if the child also had, but the point being that sometimes the prothrombotic tendency will only be solved if the abnormality is dealt with, either in the form of placing a balloon to try to dilate a vein that is being uh, occluded from the outside or pushed upon from an extrinsic compression, or in the event of an IVC, eventually reconstructing the cava by placement of stents. In the absence of that, treatment for at least 12 months would probably be indicated, with whichever anticoagulant the center has access to, and also depending a little bit on the lifestyle of the patient. For example, for patients that are not tremendously physically active, an oral vitamin antagonist is absolutely acceptable, but we will remember that the anticoagulant level remains stable if the patient has a good adherence to it. Conversely, if the patient is very physically active, one may want to do twice a day exposure to the anticoagulant to alternate peaks and troughs throughout the day to accommodate exposure to physical activity and a little bit of trauma. So athletes may prefer to either use an injectable or a DOAC, but the asterisk to the DOAC is that it remains to be better characterized in patients with these vascular anatomy-dependent events, because depending on the degree of obstruction of the vessel, a DOAC alone may be accompanied by higher than usual recurrence rate. So I've made general comments hoping that these can be helpful.
Thank you, Leo. Can I add to it? I just wanted to thank you, Leo. This is Dr. Anjan. Huh?
Yes,
So,
of
yeah,
course, Anjan. It's
yeah.
lovely. Yeah, I hope I can call you Anjan. It's a pleasure to see you
Sure.
again.
All right. So just to add to it, basically the mom has a factor V lead-in mutation as well as a heterozygous state of the fibrinogen, which was causing her hypofibrinogenemia actually. And she had basically like a DVT with a pulmonary embolism. So the
Oh, wow.
mom was on apixaban actually. Yeah?
Yes.
And I could apixaban twice a day, basically. The mom was there. Now, this child suddenly had leg swelling, and then when they came into us, now extensive thrombosis on both the left more than the right. But then when we did the MR venogram, we could not see the segment of the IVC, but there were a lot of collaterals. So which indicated that this was a prior event which has happened actually, a lot of collaterals there. Now we asked the vascular people that whether we can do something reconstruction of this because the outflow needs to be seen. So there were like varied opinions that it was risky and all. That was the thing which was said. And stent is also was because they could not put a filter because they could not go above the IVC basically. So that was one of the things. And when I did a thrombophilia screen, the APC resistance was low, indicating that factor V latent mutation is there. But I haven't got the genetics. But the fibrinogen level in this child was normal, whereas in the mom was, My only question was that with enoxaparin, he's doing well. The swelling has come down, and he's a little bit mobile, although he's not able to walk now. The question is that the family wants to go back on apixaban. So how early, like I said that at least 4 weeks of enoxaparin should be there. And then we can think about rivoxaparin, which is once a day, or apixaban twice a day. I am not very sure about the childhood states. And then if the congenital inherited syndrome is there, so is it a lifelong thing or should we think about 1 year? And then is a repeat imaging helpful in these cases? So these are the questions which come in. And then what do we do to prevent the post-thrombotic syndrome actually in these cases?
Yes, these are all excellent questions, Anjan. And to some of them, I'm afraid we not necessarily have the answer, because I'll just give you an example. Indeed, the patient may be at risk of post-thrombotic syndrome, but I've just shown you the ASH recommendation that they don't recommend catheter-directed thrombolysis routinely, even though in parallel, there's just 2 weeks ago or 1 week ago in New England Journal, another trial looking at intervention on patients with already established post-thrombotic syndrome submitted to catheter. There was a little bit of help when that happens. Be as it may, if you're thinking the lower limb is improving from a swelling point of view, after 4 weeks, it may be reasonable for you to flip to a DOAC, be it rivaroxaban or apixaban. And I'm happy it's not a female adolescent, because both have been associated with have menstrual periods. Rivaroxaban more commonly than apixaban, but that would be an option. And then hoping that the child has a normal kidney and liver function and no other drugs that could interact, even though the list is smaller. You can treat for up to 6 to 12 months, evaluate what is the residual thrombus burden, and go from there.
All right. Okay. So I've just done apply antibodies to just rule it out because that's one of the contraindications for it.
Correct.
So, all right. Thank you so much.
Thank you.
Prof, similar question. Your recommendation of systemic versus catheter-directed thrombolysis in scenario of extensive aortic thrombosis in a neonate. So any recommendation for that? Aortic in neonate.
Mhm. Usually, aortic thrombosis in neonates, as I pointed out, are associated to umbilical catheterization. And if that's the case, first, thrombolysis be systemic or catheter driven. We always need to counterbalance with bleeding risks because neonates certainly have a much higher bleeding risk in contrast to non-neonates. That's something I learned from our neonatologist and in practice. And then, if it is related to the catheter, after a certain grace period where the neonatologist feels more comfortable that the bleeding risk has decreased, you may still use the tip of the catheter to, and one can consider low dose TPA to begin with. By low dose, I'm talking about doses between 0.01 to 0.06 milligrams kilo hour, and evaluate, but that then you use it for over 24, 48, 72 hours, and you may repeat imaging once a day uh, to to evaluate the serial change of the thrombocytes. Of course, if things is much more dramatic, and you're talking about risk of loss of limb or an organ or even life, then you may need to use higher doses or use systemic doses. But again, the risk of bleeding in neonates is much higher. And in neonates would also be mandatory to give plasma to replace plasminogen because neonates have fetal plasminogen that leads to a less successful thrombolytic course. I hope that is useful.
Yes. So one common scenario which we face during our ALL treatment, 12-year-old boy with T-lymphoblastic lymphoma in induction phase and developed CSVT in the brain along with status epilepticus and started on low molecular heparin and now week 7 of the therapy. So questions are, how long do we continue and when do we repeat the imaging?
Thank you for the question. Teenager with T-cell ALL complicated by CSVT in the induction phase, which is the most common chemotherapeutic period where venous thrombotic events occur in ALL. So it depends a lot on the protocol and the ancestry of the patients. Perhaps the highest prevalence is being present on BFN based in Caucasian patients where thrombophilia has been shown to have a role, and lowest maybe in chemotherapeutic protocols such as the Dana-Farber, where asparaginase and steroids are given separately in ancestry that is non-Caucasian. Be as it may, so we would treat in a teenager for at least 3 months, but because this is ALL and usually in association with asparaginase, especially if it is PEG asparaginase, we would give full dose until 1 month after the last PEG asparaginase being administered.
All right. Can we use DOAC in this scenario instead of low molecular weight heparin?
So according to the guideline recommendations, yes. However, when you talk to pediatric neurologists specialized in pediatric stroke, arterial or venous, they express a concern because the number of either CSVTs or arterial events treated with DOACs in children is really small. And therefore, the pediatric stroke specialists are much more reticent in using DOACs for CSVT in contrast to hematologists like myself. The second point is that depending on the frequency of LPs, of lumbar punctures, it may be easier to utilize a heparinoid until the frequency of lumbar punctures diminishes. Because you may want, if you really are talking about a very recent event, you may want to do what we call bridging, which is to stop the IV heparin 4 hours before, then resume 6 to 12 hours later, provided that you've had a champagne tap, right? And no other complications. But what I'm trying to say is depending on frequency of procedures and depending on degree of drug interactions, and there are several that include DOACs, it may be more practical to use a heparinoid at first, and then perhaps once the patient has finished induction and is in a more stable part of the chemotherapeutic protocol, then eventually to convert.
After resolution of these CS with this thrombosis, can we re-challenge with asparginase?
Would you mind repeating the question, Dr. Danwa?
So after if the course is completed and the thrombosis, the imaging, so there is canalization. So can we re-challenge these patients again with the asparginase?
Excellent question. Thank you for that. The question is, can patients be re-exposed to asparaginase if they develop a thrombotic event? And so as I alluded to, it depends a little bit on the protocol. Well, the answer is yes, but with or without, if on the protocols that I mentioned, that we know that thrombogenicity is high, I wouldn't feel comfortable exposing without an anticoagulant in parallel. So on those protocols, I would probably give the asparaginase together with anticoagulant full dose again. And then once the asparaginase formulation's effect is over, so E. coli, Erwinia, the duration of residual asparaginase effect differs in contrast to PEG, right? But depending on the residual effect termination, then you can stop the anticoagulation again if the child was re-exposed.
All right. So another participant, the scenario, 11-year-old male, 11-year-old presented with sepsis and septic shock, and she developed a radial artery thrombosis. So what is your choice of anticoagulant and how long should we continue?
The current
guidelines. Radial artery.
Yes, thank you for the question. This teenager and critically ill in the unit, probably with septic shock that require an arterial line. And this sounds to me like it would have been an arterial line related radial artery thrombosis. The guidelines usually suggest full anticoagulation with an anticoagulant, not with an antiplatelet agent, for 1 week only. But in common practice, we usually tend to treat for up to 2 weeks and then do the image to reevaluate. Of course, clinically, you evaluate perfusion and findings that suggest the thrombus is not progressing before you need to escalate therapy or not. Thank you.
All right. So another question. So if patient develop line-related thrombosis, do we need to remove line immediately or should we wait for a bridge time with anticoagulant?
Excellent question. So there are two answers. For arterial lines, usually it's very helpful to remove the arterial line. And of course, in parallel to start to give full anticoagulation. For venous, for central venous line related DVT or pulmonary embolism, or mostly DVT, the previous CHEST 2012 recommendation was to give full anticoagulation between 3 and 5 days before removing the central line. The 2018 and 2025 ASH did not address it, but there have been publications with the initial recommendation to give anticoagulant was based on a death from one case report. And since there have been publications with north of 150 to 400 patients where removal without anticoagulation did not lead into pulmonary embolism. So unless it's a very massive piece of thrombus that something will flip, I would feel comfortable not giving anticoagulation for an excess. I would need to give to treat the DVT, right? But not waiting 3 to 5 days to remove it.
All right.
For venous.
Thank you. Yeah. So another question, neonatal arterial thrombosis, does it require any anticoagulant if the workup is negative? This is arterial neonatal thrombosis.
So neonatal arterial thrombosis, which hopefully I would have shown
Yeah.
in 80 to 90% of cases, is catheter related. For catheter related, thrombophilia investigation is not indicated because I read on the question, workup is negative. But nowadays, the workup thrombophilia is no longer indicated. And if the child is symptomatic, suggesting this is an acute arterial thrombotic event, there is indication to treat. Of course, we always need to ask two questions. Do I need to treat and can I treat? If you're talking about a patient that has an active intracerebral bleed, you will have to improvise, to use local vasodilators and attempt other techniques. But in general, in the absence of contraindication for an acute arterial event, yes, there is indication to do so.
All right.
Symptomatic, right? Symptomatic.
So, any role of anticoagulation in tumoral thrombosis?
Excellent question. Very short, I don't know. In North America, there is a tendency, for example, this scenario commonly occurs in inferior vena cava thrombus, complicated or not by pulmonary embolism, that we don't know if it is pure tumor thrombus or not, or that's one of the scenarios in North America, because this is data that hasn't been published, has only been presented in abstract format at SIOP. Biopsies of pulmonary embolism in those examples show a mix of tumor and what they call tumor and blend thrombus. So usually anticoagulant is favored in North America, especially because the patient has active cancer, which is very prothrombotic at a pivotal location that, if progresses, can lead to death.
All right.
So,
So the last question, in the BMT scenario, post BMT patient with line thrombosis, and as because of the post bone marrow transplant period, there is thrombocytopenia. So in this scenario, what is the right choice of anticoagulant, and for how many week or days we should continue?
Excellent question. So the question of post bone marrow transplantation, where there is obvious until grafted is completed, there is a severely low platelet count. What is the right amount of anticoagulants? And this also applies to cancer patients, right? And I can even throw another curveball. Cancer patients with thrombocytopenia and brain metastasis. What is the correct anticoagulant? Ideally, in these scenarios, if you are forced to treat because the thrombus is associated with high risk of morbidity or mortality, I would choose an anticoagulant that has a short half-life and a perfect antidote, because that's the best combination you can have in case of a bleed. Usually sometimes people ask, what about using aspirin? But aspirin, there's also a corollary of complications. Given the platelet count is already low, and you're going to inhibit the little platelets that the patient has. So you will need to risk stratify the bleeding. If it is tremendously high, you may be forced not to treat and see what happens on a day-by-day basis.
All right. So thanks once again, Prof. It was pleasure hearing you and a nice question and answer discussion. Thanks once again.
Oh, it's my pleasure. And perhaps I see that we may not have answered all the questions. I just shared my email. Feel free to I'm happy to try to answer any leftover questions that people feel they would like to send. And I again thank you for the opportunity to participate. It's been a pleasure. Hopefully this was useful.
Yeah, it was definitely. And one of the participants asked, can we discuss thrombosis cases on the emails? So thanks sharing your email, and thanks once again. Yeah.
My pleasure. If we need to do a second session, feel free. Tony, thank you very much.
Thank you so much. It's just an honor to listen to you again. Yeah. Thank you so much.
It's a pleasure. Bye-bye.
Yeah, bye.
Thank you.
Thank you. Bye-bye.